All right, good afternoon, everybody. And it is afternoon. I checked my watch. And we are, I think hopefully everybody had a chance to eat, had a chance to do a little networking, a little talking. So thankfully I'm not standing between you and lunch, but I am standing between you and our keynote speaker, so I'm going to get out of the way. And to do that, I'm going to introduce Dr. Dereck, DeLeon, the Chief Academic Officer of Cone Health, who will introduce our keynote speaker.
Good afternoon, everyone. I'm Dereck DeLeon, the Chief Academic Officer at Cone Health. And as we heard earlier before, this event has been sold out. It's the hottest ticket in town. And I wonder why, right? And what I've decided is that everyone here wants to end homelessness. Everyone here wants to make a difference. Everyone here wants for this to be the last conference we have to come to talk about this. We want to move on to something else. And at a deeper level, we actually want to be inspired, and we are inspiring each other. And I think our next speaker will actually inspire us tremendously. Dr. Sandel, Dr. Megan Sandel, has done a lot of national work around homelessness. Her talk is going to be very timely for us. She will link homelessness to health outcomes, but she will also give us some thoughts and how she in the past has created alliances and anchors within the community to make a difference. Dr. Sandel is a nationally recognized expert on housing and child health. She published the seminal report called Doc for Kids. That was a first of its kind that actually showed the effects of housing on the health of children. She is currently the Associate Director of the GROW Clinic at Boston Medical Center. She actually is a principal investigator with the Children's Health Watch and associate professor of pediatrics at Boston University School of Medicine and Public Health. Let's give a warm Greensboro welcome to Dr. Megan Sandel.
All right, I think I'm going to go TED style. Can you guys hear me? Hear me in the back? All right, great. So I am so pleased to be here today. When Beth and the conference team called me up and said, would you be willing to come to Greensboro for the Housing is Health Conference, I jumped on the opportunity. And in a lot of ways, I really think that Greensboro has all the ingredients that are needed to do the prescription for healthy communities. And I think there are just so many stars aligning, and I wanted to come and see it for myself. I actually said, not only was I gonna come and do this, I wanted to come visit Cone Health tomorrow so that I could be able to give, honestly, a similar talk in the same language. There are ways in which we as health care sectors and health insurers can work alongside our housing sectors, along with city government, along with banks, along with corporates, along with educational institutions. These are the ingredients of healthy communities and how we can work together. I'm going to try and talk for about 30 or 40 minutes, give about 20 minutes for questions, because I really wanted this to be a dialogue. And I'm just really excited to learn more from you and to be able to share what I've seen from around the country. All right, so when we think about housing being health, what I say is that a stable, affordable home is a prescription for good health, right? As we think about kind of the roadmap of the talk, think about it kind of having kind of three parts. So the first is I'm going to talk about the dimensions, the ways in which housing and health are connected. This has been a real journey for me. When I first got interested in housing, I was a pediatric intern. I had just graduated from medical school. I admitted a child to the ICU with asthma, and I was tearing my hair out. Why did this kid get sick with asthma? And I ended up asking the family a really fateful question. I said, what had changed? And they talked about getting a cat. Why'd they get the cat? Mice. They had found mouse droppings in this child's bed, and they were upset. And they said, what am I going to do? And they talked to the landlord, and the landlord wouldn't do anything, and so they got a cat. And unfortunately, the child was allergic to cats, and that's why she ended up in the ICU. And for me, it was that eureka moment early in my career that the prescription I wanted to write was for a healthy home, and that wasn't stocked at Boston Medical Center's pharmacy. And I think that as you'll hear over and over, more and more, we are going to be able to fill that healthy housing prescription. We are going to be able to do that. But it's really evolved, right? I'm going to talk about kind of the dimensions aren't just about quality, it's also about stability and affordability. It's about location. A healthy, stable, affordable home that's not in a neighborhood of opportunity may not maximize health. I sometimes have coined the phrase that a home can act like a vaccine. It keeps you healthy now and in the future. So I'll just share a little bit of research about why that underlies. Why do we view vaccines as good investments and why we shouldn't view homes as good investments as well. I then will talk, just especially in the housing world here. In fact, let me just do this quickly. How many people here would consider themselves from the housing world? All right, a fair number. How many people here would consider themselves from the health world? Okay, so what I sometimes will say is the people who raise their hands for the housing, you're in the health business, right? People aren't paying you enough for that, and so what are ways in which we can start to talk about that? And in a lot of ways, the term of art for us in health system is called population health. So I'll talk a little bit about my love-hate relationship with the term population health and why we need to start to understand it more. And then the third part of the talk will be talking about this idea. How can the health and housing sectors exchange value? How can they enter into relationships, ways in which we value health and we value what others do, and start to think. I may be a little controversial in that part of the talk, but I'm really trying to stir conversation. And then I'll mention a national campaign that we're part of called Opportunity Starts at Home. And I always end my talks with talking about homes as a route to health equity. All right, so fasten your seatbelts, let's get started. So the evidence on home quality is profound. It has been around for decades, if not centuries. What I tend to say is the evidence on it there's a variety of ways in which housing quality impacts health. The one way that some people don't always connect is accidents. So once you take kind of motor vehicle accidents out of the equation, the leading cause of death for kids is home-related stuff. Fires, drownings, things like that. And so as we think about it, and more as a pediatrician, I focus obviously on kids and families, but elders and falls can be extremely difficult events. And I was really excited to hear that there's a capable intervention pilot going on here. There's really great evidence-based ways that we can reduce those types of falls. And so that I just want to always, when we say quality, not just to think of mold and cockroaches, but to think also about accidents and preventing injuries. Obviously, I first got interested in this in terms of how do things like development and worsening of asthma be related to the home. And that is not just mold and chronic dampness, it's being exposed to pests in the home. I like to point out tobacco smoke. 86% of kids that are exposed to tobacco smoke are exposed in their home. So ways in which to do smoke-free housing policies or people having safe places to smoke outside are very powerful interventions. We have to talk about lead. We kind of thought, oh, we had solved lead, but no, we haven't. And I think that in a lot of ways, we're understanding lower and lower levels of lead exposure as being meaningful, so we can't not talk about it. And then lastly, I think it's really important that we document this idea of energy costs. Housing quality and energy costs are tightly related. If you're paying so much to heat your home, you may not have enough money to eat. And thinking about cooling costs and how cooling costs cause the same problem. And so all of those are wrapped up into quality. Where we don't, I think, spend enough time is actually on the impact of home quality on mental health. We spend a lot of time on physical health, but mental health is actually maybe as expensive, if not more expensive, and actually really changes the life course. This was a study that was done by Rebecca Levine-Coley in Boston College, where she looked at the impact of home quality on kids' behavior problems in school. And she basically showed that the leading, strongest predictor of emotional and behavioral problems in schools was the fact that they lived in substandard housing. And a lot of that traveled through parental stress and the things that parents were feeling stressed, they had difficulty parenting, the kids carried that into the school system. And I think it's just a really microcosm that a housing intervention is not helping just a single person. It's helping everyone in the household. It's helping the kid and the parent and their grandparent. It's not just affecting that family, it's affecting the kids in that school because that kid is carrying that with them to the school environment. And so it's not just that we talk about physical health, we need to talk about mental health as impacts. I think the other thing that we talk about right now is what I sometimes say is the stability iceberg. We spend a lot of time talking about homelessness, and I think we should talk about ending it. But the reality is that the stability is an iceberg. Homelessness is the part of the iceberg you can see. There's a lot of iceberg below the surface. And so when we think about the hidden homeless, people that are housing insecure, people who are doubled up, who are moving frequently, who are having difficulty kind of with a stable, a lot of that root cause is unaffordable housing, okay? And so as we think about it, we started looking at this in some of the research that I do with a research policy network called Children's Health Watch. We just published this last year in the Pediatrics Journal, and we looked at 22,000 families in 5 cities, in Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. We interviewed them in healthcare settings, in pediatric emergency departments or primary care clinics, and we asked them simple questions about their health and about their housing stability. The first take-home message of this research is that it was incredibly common among renter families that they had at least one form of housing instability. Over a third of families that were renter families and on a public form of insurance had a form of housing instability, either reporting that they were behind on rent in the past year, that they had moved at least twice in the last year, or that they had a history of homelessness or were homeless currently. So that was just shocking to us. I think we knew it was common, we didn't know it was gonna be that common, okay? Each of these individual, right, whether they're behind on rent, whether or not they're multiple moves, or whether or not they're homeless, all impacted health in kids and their parents. The second thing that was interesting to us is we tried to look at the overlap, right? We were like, like it's really common. Is it just a certain subset of families that are driving this? And it's no. When you look at the overlap of the housing instability, 86% of the time if you were positive for one form, you were only positive for one form. So the behind on rent group was different than the multiple moves group, was different from the homeless group, okay? And so again, if we're talking about ending homelessness, which we should, that's only part of the problem in terms of housing stability and health. We have to end people making trade-offs with their rent, or falling behind, or having to move frequently and be doubled up. Those are the issues in terms of trying to impact health. I think the last piece that I think was really shocking to us is when we started stacking up the health effects of these 3 forms of homelessness. We looked at those that were stably housed, that's the smallest of those blue bars. But then when we looked at those that were homeless, behind on rent, or multiple moves, we knew homeless kids and their families would be sick, but we did not anticipate that the families behind on rent would look just as bad as the homeless families. And so I used to think about it as a continuum, right? You start to have housing stability, you behind on rent. Then maybe you have multiple moves and you get a little sicker. And then you get to be homeless and then you're the sickest. No, they're all 3 really sick. And so as we think about ways in which to impact housing stability, I urge us not to just focus on homelessness, but to focus on those that are on the brink and to be able to have a more holistic strategy for stability and affordability. All right, the third piece is location. This map is not meant for you to see it granularly, but to see it in detail, in the overlap. So when you see the overlap between the black dots here and the dark red neighborhoods, what you're looking at is a map of New York City. And you're looking at neighborhoods that in the 1990s had concentrated poverty. More than 30% of people in those neighborhoods lived below the federal poverty level. I just want to gut check my audience a little bit. Does anyone know what the current federal poverty is for a family of 4? What the average? It's about $4,000, right? Like it's low, right? Family of 4 trying to live off of that. Can you imagine doing that in New York City, right? Where you're 30% of everyone in a neighborhood is below that, right? And then what the red areas are places 20 years later that are still concentrated poverty. So what you're talking about is a generation of kids growing up in a neighborhood where at least a third of the people around them are living in more extreme poverty situations. More similarly, we've started to look at maps that are of opportunity. And so the Kirwan Institute developed this opportunity mapping system where they said, are these neighborhoods high opportunity, medium, or low or very low opportunity? So what this map shows is this is the city of Boston. The core neighborhoods of Roxbury, Dorchester, and Mattapan, where predominantly African American and people of color live, are low opportunity. That's where predominantly my patients live, I apologize. And what we ended up doing was we took blood pressure readings from our 3-year-olds in the electronic medical record. My partner in this is Dr. Renee Boynton-Jarrett. She leads a network called the Vital Village Network. We had been asked by the Academic Pediatric Association to publish on neighborhood level interventions for reducing poverty. And what we show here is that when you map opportunity and you map elevated blood pressures of 3-year-olds, the circles that are the biggest are the highest prevalence of elevated blood pressures. You see the lowest opportunity neighborhoods have the highest levels of elevated blood pressure. So have no doubt, the social factors, your zip codes, are biologically changing potentially the blood pressures of your kids. So when we talk about this is an imperative, right? We are talking about ways in which we need to act now in order to change not just stable, affordable homes, but creating jobs and creating educational opportunities in these neighborhoods so that kids and families can thrive. All right, so I'm going to shift gears from kind of quality, stability, affordability, location. I'm going to talk to you about why do we vaccinate? Like, why is it really important? The first thing is, like, we vaccinate because it helps you protect you against disease, right? But we also protect you in a sense of what's called herd immunity. And so the cartoon that you can see, and hopefully people in the back can still see it, is why herd immunity is so powerful. So the top cartoon shows people who are blue, who are healthy right now, but they're not immunized. And what you see in that is a couple people come in, they're red, they're sick, and everybody gets sick, right? And then you see the middle cartoon, and what you find is, oh, you now have, most people are still not immunized, they're healthy. You have a couple yellow people, those are immunized. A couple people come in and sick, everybody gets sick. The bottom cartoon is the key. In that community, almost everybody is immunized. You have a couple people who are healthy and unimmunized, a couple people come in that are sick, and what you'll notice is some of those unimmunized people are still protected. They manage not to get sick. And so in that way, as we think about housing, it's really important we don't just talk about it as an individual benefit. It is something that benefits us all to make sure people have stable, affordable homes in great neighborhoods. And what we know is that that economic benefit to the community is important. We know that when we don't vaccinate, we have outbreaks, we have crises, things like what's happening in California and in Portland, Oregon. So we actually published an article over 10 years ago, it was actually 2005, where we looked at this idea of how does a stable home affect families. And we looked at a kind of a high-risk group. These are families with young children, 0 to 4, that were food insecure. And we compared those food insecure kids that had a housing subsidy and those that didn't. And what we found was that the food insecure families that had a housing subsidy were 2-fold less likely to be underweight than the families that were food insecure and didn't have a housing subsidy. So think about that for a second. The housing subsidy program that helped you not pay too much for rent made sure that your growth didn't get stunted because you were hungry. So that provided you that benefit. It provided you that immunity against that threat. So why do we invest a lot in vaccines? Well, I use the example of chickenpox or varicella vaccine, right? Why do we do that? And you would say like, oh, because people don't get chickenpox. You want to save money on that. But actually, when you really look at the healthcare costs, if you just look at healthcare costs alone, it actually costs you money to vaccinate. You end up with $2 for every case averted. But when you take into the societal costs, for every dollar you spend on a chickenpox vaccine, you get $5 back societally, okay? So what I say is I vaccinate kids against chickenpox to make sure the kids don't get chickenpox, but mostly to keep their parents at work. That's the impact. That's where you get the return on investment. So we can't just talk about the individual, we have to talk about the society. We have to talk about the ripple effect of these in order to be able to unlock dollars and think more creatively. All right, so I'm gonna shift gears and now talk a bit about population health. So I say I love and I hate population health. I love it in the fact that it's my sector, the healthcare sector's way of finally getting out of the individual interaction and starting to think on a population level, to start thinking about communities and start thinking about ways in which we don't just think about individuals, but we can start tracking on a larger scale. I hate the term population health because it kind of subsumes this other term called public health that's been around for like 2 centuries and has a lot of great ideas and a lot of ways in which to solve things on a population health level. I've actually started to use terms where I talk about individual health, I talk about population health is the people in my health system, and then community health is everyone who lives in the community, just to try and not confuse the terms. Because what some people say is population health, they mean actually community health. And when we in the healthcare sector say population health, we only mean our patients. And that's not to say we don't care about everyone else, but when you start talking about financial models and how do you start to make stable, affordable homes, you have to be able to talk at it at the 3 levels. The other piece that's really important to keep in mind is population health. This is often we talk about the population health pyramid. There's kind of a not so dirty secret in the healthcare world, which is that a small percentage of people use most of the dollars. The top 5% of people use 50% of every healthcare dollar. And so when we start talking about where are we going to find the money for this, you start saying, I can find it at the top of the population health pyramid. You heard it earlier, right? You have an $85,000 bill for asthma, and if $8,500 can fix it, then you start thinking, oh, what can I do with those savings to try and make change? And so that's part of it. I do think part of the population health pyramid is this middle group, not just the high cost, high need top 5%, but this rising risk group, this group that's starting to get sick. Can you catch them earlier, prevent them from becoming the high cost, high need? And then sometimes, unfortunately, in population health, we forget about the bottom of the pyramid, right? We forget about, like, how do we keep people healthy in the first place? We similarly sometimes in the housing world end up with these segments too. We only talk about homelessness, the top of the homelessness pyramid. We then sometimes talk about housing stability and housing quality as the rising risk. We don't often talk enough about how we get people into home ownership or being able to help them with their housing in a more proactive way. And so how do we start to think about these 2 pyramids together? How do we kind of break this cycle so that we can talk about population health not just from a healthcare perspective or a housing perspective, but how do we merge them together? One way we try and do it is start to come out with what are the costs, right? What are the costs of these kind of rising risk groups and or other groups that we can target? We published this in Pediatrics last year about the timing and duration of homelessness and its impact on health. One of the scary things of our findings here is that we were interested, we had published previously that, no surprise, if you're homeless while you're pregnant, you're more likely to have a prenatal, a preterm baby or a low birth weight baby. Not shocking, but don't get me wrong, like in the published literature, people say, what's the evidence base? You can cite our study, it's there, you know. But I think the issue is more, how do you then track that over time? And what we actually showed was that if you are homeless in the prenatal period, but you get housed, that risk carries on into childhood, even after we control for the low birth weight and the prematurity. So as we think about it, high-risk pregnant women, we should be investing in them a lot, because if we can prevent them from becoming homeless, we can actually have healthcare savings now and in the future. I think the other piece that was important was the duration of homelessness. And in this case, we looked at young kids 0 to 1 year of age, infants, and how long they were homeless versus kids 1 to 4 years of age. And if they were homeless more than 6 months, the infants actually were the sickest. 250% fairer, poor health, much more likely to be hospitalized and developmental delays. And so it's a both and. We need to prevent homelessness before it occurs, because if we don't, that toxicity carries with you. And we need, if you get to be homeless, we need to get you out of homelessness fast. Because if we don't, again, we're gonna see that health effects long term, and particularly infants are a really critical, vulnerable population. And then we tried to put a number on it. What's the costs we're paying right now in terms of healthcare utilization related to homelessness? It's $230 million. Half of it's in infants, half of it's in this 1 to 4 year olds. But it's not a nominal amount of money that we think is just attributable to people being homeless that could be avoided. In the adult world, we focus a lot now on these high-cost, high-need patients. And this is from my hospital, Boston Medical Center. We looked at our 50 highest-cost patients, people who cost over $100,000 a year to us. And guess what? We found a lot of them have chronic disease, heart failure, mental health conditions. But we found almost half of them are homeless. And we found that, yes, when we put complex case management in place, we get them to be a little better, but we don't really change their trajectory of health. And so it made our hospital start to think about, not only do we need to think about who these people are, but we have to think about where they live. And so we took those high percentages, people, we call them our top 2 or 3% of utilizers, these more than $100,000 patients, and we asked what zip codes are they living in now? And guess what? They live in 5 zip codes right around our hospital. They live in the 02119, 02128, 02118, 02124, 02125, 02121. And so we said, we need to start thinking about this, not just on a population level, but on a community level. How are we going to change this? And so we started to build housing partnerships. I just want to be clear, my hospital is not becoming a landlord, right? We're not building housing, we're not doing that. We're investing in housing partners in these neighborhoods where we know our highest cost patients live, as a way to try and change not only their population health utilization, but the community's health as a whole. And so we have dedicated $6.5 million into a housing initiative to build different partnerships around different themes. So one area was, we went to our housing partners, we said, we may have unlocked some money to do a housing initiative. What's your pain point? And so Nuestra Comunidad, a local community development corporation, said, guess what? We're building this beautiful new building. The first floor is empty. We want a healthy grocery store, co-op to come, and they can't get financing. And we said, maybe we could help finance a grocery store in this neighborhood. We said another group, Codman Square, got a building out of foreclosure, where a landlord had totally dilapidated, abandoned this building, didn't do any repairs. They got the building out of foreclosure, but now they need to do a ton of repairs. And we said, maybe we can help you with some of those repairs. Maybe when you repair the units that now can't pass code, maybe we can put some of our patients there as a way to get them out of our hospital and into stable housing and be healthier. Some of this is service collaborations, ways in which to put on-site services to help people in the building and the communities. Some of it's honestly investing in respite and transitional stabilization housing, working with our amazing local Boston Healthcare for the Homeless partner and Pine Street Inn. I was excited to hear that Brooks Ann is here from the Boston area, now in the North Carolina area. You have an amazing resource of someone who understands respite and stay-in programs and ways in which that can be really powerful. And then we actually put some of the money in, honestly, a stable housing initiative where we said to the community, you come up with the ideas. What are the things you want us to focus on in order to create stable housing? And I'm excited. We put $1 million into it. Since we announced our initiative, Children's Hospital in Boston has matched our $1 million. Brigham and Women's have dedicated $750,000. So these are ways in which health systems can work together. And then last but not least, we invested in an equity fund, something called the Healthy Neighborhood Equity Fund. I'll tell you a funny story. I thought they were talking about health equity. I thought it was really cool. This fund was talking about health equity. And no, equity fund is a financial product. But it is this way in which, those are ways in which hospitals can start to look at their investment portfolios and how they can do it. United Healthcare has been a leader in this space, thinking about ways in which insurance can do this. And I know there are others that are starting to think, how can they use their investment portfolio for social impact as much as financial return? All right, so this is the third part of the talk. This is the controversial one. Get ready. So I think we should do what David Erickson calls a marketplace that values health. And what that means is, are there ways in which the two sectors can exchange value, can enter into relationships where you're not just delivering, again, this financial return, but this health return, and you value it, okay? So I've talked a little bit, right, like, I talked about healthcare's pain point. We have these high-cost patients, particularly now that we're getting paid differently. What are the ways in which we can now shift our thinking to being more prevention-oriented? But what's the housing sector's pain point, right? Can we find a cure to each of our pain points? So obviously, the housing sector needs capital, right? You guys need money to build new units. You need ways in which to renovate existing housing stock. You need, honestly, ways in which to attract healthy retail and other types of businesses to the communities. You need to have money to cover resident services. You need sometimes operating subsidies to make those units work, or sometimes rent subsidies to be able to help be the gap between low-wage work and what you can pay in rent. So money, right, but there are different forms of kind of money. Guess what the healthcare sector has? We have money. Sorry, I should say, what do you have of value? I'm skipping ahead. So what do you have value? You have value, you have units. And I know you always feel like you don't have enough units, but you have some units that you can think about. You have renovation or turnover or ways in which you can provide value that way. Honestly, you guys have a proven way of ending chronic homelessness. You've done an amazing job of networking in those ways and thinking about it. You know, you have amazing resources like the Greensboro Housing Coalition. There are amazing housing organizations out there that work. And then many of you have on-site residential service models that really, like monitoring families, connecting to them, being able to link with medical case management, do wellness, not just health wellness, but financial wellness, asset building, things like that. So you have a pain point, which is money. You have a lot to offer for value. Now I'm going to talk about it. What does the healthcare sector have? Money, right? And we have a lot of different forms of money. So I always want to try and highlight that it's not a single type of funding stream. So the first is that we have insurance, or sometimes provider, or you're going to hear this term, accountable care organization. What are you guys going to call it in North Carolina? Are you going to call it ACOs or something different? Erica, what are you going to call it? ACOs? No? Okay, so it's called different things in different places. Some people call them CCOs, right? Community care organizations. But you're going to basically think of an accountable care organization, or an ACO, as here's a global budget. You're now accountable for the care of a group of people, okay? And so in that, we have insurance dollars that are now getting a lot more flexible in what can get covered. That's the good news. I think the bad news is that you're going to have these new entities that are going to have to figure out how to spend money in a different way than how we traditionally were spending money in a fee-for-service way. We do have this concept called community benefit, which is not-for-profit hospital systems need to document that they're doing a certain amount of community benefit consistent with what they ought to be paying in taxes if they were for-profit. And so this is an area that there can be more and more. People can ask me, like, where'd you find $6.5 million? Well, we were regulated under the state of Massachusetts community benefit, that when we built our new hospital tower, we had to do a community health initiative. And we convinced, I was going to say, yeah. But there are other programs, sometimes they're called certificate of need or other things, that those are ways in which we can start to think about tapping into a more philanthropic dollar. And then the third one is our investment portfolios are a real way of which not only I think hospital systems, but health insurers can start to think about a new dollar. It's a dollar you already have that you just redeploy with a different intentionality. So all three of those are really important. We also have political capital. And I think that's really important as we think about both state and federally, how we need to get government back in the housing business. And I think your local city government is an example of amazing leadership, but how do we get the state and the feds to come to play and bring new dollars to the table? And then service dollars. Healthcare, we buy services all the time. We buy caseworkers, we buy community health workers, we buy health and wellness. What are the ways in which the services you're providing can be linked into ours? All right, so then how could the two sectors exchange values, okay? So I'm gonna say right up front that some of this may require a fair housing waiver. So this is where the hate may come into the conversation, or not the hate, but the anger. I think to an extent, what I'm talking about is, are there ways in which you can create access for units in a way that would potentially decrease healthcare costs, but also potentially benefit everyone in the community, okay? So there can be set-aside units for investment, ways in which you have units for higher utilizers, and that you could therefore invest in the portfolio, maybe at a lower rate of return, in order to make sure that you be able to place someone who's in your ED and your hospital 10 times in a year. How can we get them stabilized into a unit? Are there ways in which we could do set-aside units for service dollars? We put on-site services into housing development. What are ways in which we can make sure we place someone there so that the community health worker can check on them? There's a lot of, I think, telehealth stuff that people have started to think about in this state, which I think is really exciting. What are ways in which we would invest in the telehealth equipment or the other things, and how do we place people there that we want to watch, and therefore that benefits everyone in the units themselves? Are there ways in which we can think again around set-aside units for broader developments, more community development, where some of it may be supportive housing, but a lot of it's actually going to be affordable housing for everyone in the community? Are there ways in which we can invest in that first floor retail in order to bring a grocery store or another types of business to the neighborhood? And then flex funds for landlords. Those are ways in which you can do it for rent, you can do it for repairs, you can be able to think of a lot of different ways. There are a lot of great models out there. LA has an amazing model around flex funds. I think there are ways in which you can pool resources in a way that creates more flexibility and be able to solve for this problem. This looks like pilots are already underway. In Boston, they started to look at this high-risk pregnant women pool. They took dollars from the local health department. The Boston Public Health Commission had their Healthy Start initiative to reduce infant mortality. They had the Boston Housing Authority that really wanted to kind of lean in around health and housing. They married and aligned those $2 together, and they basically said, we're gonna serve high-risk women who are housing unstable, not homeless yet, and we're going to try and see whether or not we can reduce infant mortality and reduce healthcare costs. It's an amazing pilot. It's been incredibly successful. Shows how we can, again, align sectors to value. And I just want to kind of highlight, we say oftentimes we don't have enough money to do this, and what I say is it implies somehow we don't think we're paying a cost right now. And so I showed you guys that research that we did from pediatrics. We tried to put actually a number to that. What if every family in America had a stable home, wasn't behind on rent, didn't have to move frequently, didn't become homeless? We conservatively estimate that we think we could avoid $111 billion over 10 years. Like conservatively, right? Like we're just talking about like maternal depressive costs and caregiver costs. We're just talking about kid kind of costs and educational costs. We're not even talking about chronic disease costs. We're not talking about other things. This is like congressional budget analysis, and I just want to say, like, I think this is what we should be asking for. This is the type of money that we can avoid spending if we are doing this upfront investment in stable homes. I'll just point out that we do have a national coalition called Opportunity Starts at Home, which is trying to talk about this housing not just from the housing sector, but from the health sector, the education sector, the economic empowerment sector. Are there ways in which we can all work together to acknowledge that opportunity starts at home, and so we should start investing in it differently? All right, I have one more slide, and then I'm opening it up for questions, so get your questions ready. So I tend to end every talk with this idea of what is quality and what is equity, because I don't think they're the same concept, and I really want everyone to understand equity and how homes can be a route to equity. So this is my favorite cartoon. How many people have seen this particular cartoon? All right, some have. Some people have seen the fence, right, where people are overlooking the fence. I like this one a little bit. I don't like fences and people, but I think it's more of, right? But anyway, I like this one. It is around this apple of opportunity, right? How do you get to it? And so on the equality side of the slide, what you see are three heighted people. You see a tall person, a medium height person, a short person. If you treat them all equally, if you give them each one box to stand on, the tall person gets to that apple of opportunity. The medium height person gets closer, the short person gets closer, but it's still pretty far, right? On the other side, if you treat them equitably, if you give them each what they need in order to get to that apple of opportunity, you give the tall person one box, you give the medium-high person 2 boxes, you give the short person 3 boxes, they all get there. They all get to that fair shot. So the inherent tension in equity is that to get people to that same fair shot, you have to treat them unequally. You have to give some people more. And the other part that's really important about equity is people did not get to be different heights by accident. This is systemic racism and oppression that have designed this for decades through redlining and other things. And so we need to be able to talk about, thank you, no, it is. And so when we talk about healthy communities, we have to talk about equitable development. And we need to talk about more going into certain neighborhoods, and we have to be okay with that, and we have to frankly honor it and hold us accountable to it. And those are the ways in which we're going to get everyone to that same fair shot. And those are the ways in which we're going to, if we all get around the table, right? Healthcare, housing, government, banks, universities, that's where you will intentionally be able to create this ecosystem that will give everyone that fair shot. And I just want to thank you guys. I know you can do it, and I'm really open for questions. Thank you. Oh, we got one in the back. Sorry. All right, repeat the question because I caught the first part, okay. CDC, and then I just want to make sure when you say CDC, you mean Center for Disease Control or Community Development Corporation?
No, yeah. Yes, I don't hear much mention of the CDC metrics, the Centers for Disease Control metrics on live, work, walk, healthy communities in the development process. And I'm wondering if you see the future of development for resilient communities driven by healthcare providers using those metrics, particularly in light of the rise of opportunity zone funds, which are lacking direction and policy around the possibility of creating more homogenization, more displacement. How are the healthcare communities, you think, taking a role in that conversation?
Yeah, I think it's a really good question. I think I'm going to answer it in kind of three parts. I think one is in an ideal world, honestly, we as healthcare institutions would employ urban planners, right? I actually took a little mini sabbatical about 3 years and started to just spend time at my local Boston development. It used to be called the Boston Redevelopment Authority, BRA. It's now called the Boston Planning Development Authority. I will just say a funny story. So I've been doing housing work for probably 20 years. So I actually have a lot of friends in the housing advocacy community. And when I told them I was going to spend a day a week at the BRA, they were like, why the bleep would you want to do that? They were really super negative on it because not everyone views that type of planning in a positive light. That being said, I think planners are your best friends, right? Like when we hired, in fact, I can't say enough nice things about planning. Planning is what you need to do. You need to invest in planning. If you don't plan, it's not going to happen well, and you need to do that. I will say it's been interesting for us when we hired our evaluator team for our housing initiative. The Department of Public Health required us to hire. I hired the Metropolitan Area Planning Council, the local urban planning or the local regional planning agency, to evaluate us on our health impact on the community level. I will point to some good resources. I think Build Healthy Places Network has amazing resources. I think that they have 5 principles that I think are just amazing around how to think about it. So I think the first is, yes, health systems should be thinking about this. The second part of my talk is we're pretty micro-focused right now on staying open and not losing our shirts. And so the reason I say that it's just really important that we somehow stack the conversation between investing in healthy places and solving our pain point, which is people who come to our ER literally 120 times in 90 days, which you have to admit is hard to do, and yet we have somebody like that. How do we bend that cost curve such that we can free up the dollars to be able to think in the broader view? And I think people have tended to think of them in isolation, and I argue we should stack those conversations together. Because otherwise, if you just talk about healthy places, you're going to be in the charity part of the board discussion. And if you're not in the business side of the board discussion, it's never going to feel like your core operating principle. All right? The third part of the answer is I don't really understand opportunity zones. I think, first, full disclosure, I sit on a big housing board called Enterprise Community Partners. I joined the board about 3 or 4 years ago. It was like going back to medical school. Like, I didn't understand any of the acronyms. I spelled out LIHTC instead of calling it LITech. I looked like an idiot. It's just a different language. And I feel like opportunity zones, as far as I understand them, it's dangerous how unregulated they are. And so I really, what Boston ended up doing was basically only designating areas where they already controlled the land. So they felt like they had more control. Obviously, it's a little bit like they've already been designated, but I do feel like there have to be ways in which we make them reach their potential and avoid as much unintended consequence as possible. I do think they are opportunities to bring new investors to the table. Andy and I were actually yesterday in DC at Fannie Mae talking about housing financing and how housing and health sectors could potentially create new investment vehicles for this. So I think that's a conversation. I'm not someone that writes off opportunity zones as evil. I just think they're a cautionary tale of how you bring unregulated money. And I think I'd like to see them a little more regulated so that they have more equity and not just free money. Okay. Oh, you're welcome. What am I doing on time? All right, good, okay.
Questions?
I've wowed you all. All right, good.
See you
Thank you.
I got you.
Yeah.
So taking the equality and equity one step further and changing the tree instead of the people. That's why that fence graphic is good. You remove the fence.
You remove the fence, I agree.
So a question around that. Changing housing markets themselves. There are all kinds of neat things out there to create permanently affordable housing. Land trusts, deed restrictions that say only to families that make X percent of area median income, or other things like that. How about changing the marketplace? What are your thoughts?
Yeah, it's a really good question. I joke a little bit that, so I'm a pediatrician, and I spend more time talking like a banker now than I do actually as a, which is no offense to bankers, but really I actually think that most of the health inequities that I'm asked to treat are financial at their root cause. And therefore, if I'm going to get to root cause, if I'm going to go upstream, I do need to actually understand and start to think about financial vehicles, 100%. It's made me actually get a lot more engaged on home ownership models like community land trust. We have a really amazing one in Boston called Dudley Street Neighborhood Initiative that's incredible. And I think there are some models of, certainly in the foreclosed home pieces of occupying homes and then figuring out ways. And as I've started to think about it, if we think about it in an enabling environment of financing vehicles, I do feel like there also needs to be the pipeline of deals or of opportunities. So that is where I think on some level, either acquiring dilapidated housing that's in the hands of bad actors and or making new development that potentially is denser so that you have more units as a way to build in more affordability also seems like a really good idea. Are there ways in which you can build in homeownership opportunities for people so it's not just affordable rent that honestly sometimes inadvertently traps people in having to fit a certain income and doesn't allow them then to increase their income? All of those I think are policy level solutions we should talk about. I'm just going to point out that the third piece of it, if you talk about like financing vehicles and pipeline of deals, is community engagement is the third part. That, Brett was telling me a little bit more about the background of the acquisition that was happening and the fact that like Greensboro Housing Coalition was holding that landlord accountable such that he finally gave in and sold, right? And there's a similar story happened in Cincinnati, right? They started mapping the medical legal partnership cases, right? People coming in, being threatened with evictions, and oh, by the way, it's the same landlord that's threatening all these patients. Oh, they're taking HUD money and not actually doing any good renovations with it. Oh, by the way, let's force the sale. So I think community engagement is really important. I'm just gonna hold up one group that I've been really intrigued with of putting together is the healthcare advocates of the states and the housing advocates together I'm going to make a call out to Jenny Cooper from Benchmark if she's here. There she is. So I think we have started to partner with Community Catalyst, which is like a national organization doing really great community advocacy, certainly the Affordable Care Act and others. And no, I don't want to talk about what happened yesterday. But I think the issue is more like are there ways in which, because if we truly believe this is about health, it actually isn't about healthcare coverage alone, right? Like the community and the housing and the economic opportunities, that's health, right? And so can we put those advocates together, and can we fund and value community engagement as that third pillar? Because what I've learned is a lot of development doesn't happen because the community doesn't feel listened to. So of course they're gonna go to a planning meeting and be like, no, thank you. And instead, if you listen and talk to them from the beginning, then if you have the pipeline of deals and the financing, then stuff gets done. But that piece, no one talks about it enough, right? And honestly, the Josie story, I just like, who's gonna write that book? Like, I wanna write, I'm buying that book. First of all, I already want her autograph, but like really, like that's such a great story, right? That's resilience, right? Everyone talks about like bioterrorism and all these things we need to do, and no, like really, that's resilience. That's community level resilience. Nobody pays for it, or I shouldn't say nobody, it's just not valued enough, right? And that is a marketplace that we need to value and put in there on the real level. So, thank you. Yeah. All right, well, thank you. You guys have been an amazing audience. I really appreciate it. Thank you.
I think we have one more. I think we have.
Oh, you got one more? Oh, sorry. See, I don't want to, yes. I'm cutting off soon.
Hello, I kind of want to piggyback off the last discussion.
Please.
And talk about, from a community organizer standpoint, that one of the biggest issues that I've seen is like the trust issue when it comes to like the healthcare and the housing industries, when it comes to low-income communities, as the fact that most of these things aren't going to work unless there's a resident-led piece, and the fact that most residents who come forward end up suffering in some capacity. And then also traditionally, most low-income people have trust issues when it comes to the health industry because of things that have happened over the years. And so what I've been struggling with is how do we make, I talk to residents all the time and make promises, but there are so many more entities involved that sometimes even what I say, I can't back up.
Yeah.
And so as a community organizer, talking to someone in the health industry who is really out here for the communities, how is it that we're getting the point across to residents that they are not only going to be listened to just to say they were listened to, but to actually implement in a more meaningful way where they're actually at the table and that they actually get the information in time enough?
Yeah.
To be able to do something about it. And I know that's a loaded question, but
it's a good question.
Yeah.
Yeah, no, I actually really appreciate the question. I'm gonna answer it a couple of different ways. I think the first is, we talk about community engagement a lot, but it is kind of like a checkbox, like, oh, I held a community meeting, check the box, right? Community engagement is really, there is like, and I've really tried to search for the metrics here, where you could say what is authentic community engagement and what isn't. It's hard. It's like a secret sauce that you kind of know it when you see it. I do think, though, it is really important as we think about, I think it was mentioned on the panel, this concept of ecosystem. What is a healthy ecosystem where you have a rich community engagement? Here, let me stand so you can actually see me. And then someone else can't see me, but that's right. I think it's, there are the, there is this kind of concept, and I think the de Beaumont people have talked about this, like who's the quarterback, like who's at the center of the wheel, and who's the hub, and who are the spokes, right? In its best iteration, the community is the center, right? The community is the quarterback, right? And to an extent, the Greensboro Housing Coalition in that story of the tornado was the quarterback, right? I think more and more we need to take that framework And it's going to look different in every community, right? I think it was mentioned in the Build Health people talked about Iowa. So in Des Moines, Iowa, I think it's like the Polk Housing Trust that's like the quarterback. So that's who it is. In some communities, it ends up honestly as the health system. In Columbus, Ohio, the Children's Hospital, Nationwide Children's, ended up as the hub. I think what I would say is it may be that we need to more, again, intentionally map our ecosystem, more intentionally say, here is who is the hub, who are the spokes. I sometimes joke a little bit, in Boston we have a problem, everybody wants to be the hub, right? No one wants to be the spoke, right? Like I'm the center. And so I actually think, I joke about it, I meant it when I said I think Greensboro has all the ingredients because you're a good sized city, right? You're not tiny, tiny. You're not enormous. Most people know each other. You can sit down. You already have amazing things like the Greensboro Housing Coalition. You have, I think, some exciting things happening on the healthcare side. It's a little scary how we're all entering, or like kind of this sector is entering into value-based payments. You've negotiated, honestly, the best Medicaid waiver out there in terms of paying for housing and food services, like just an incredible waiver. And for those that don't understand what that means, Medicaid regulates what it pays for, and then it gives states permissions to experiment. And North Carolina really negotiated a great experiment where they said, we'll pay for housing repairs, we'll pay for inspections, we'll pay for, if you need transitional housing, we'll pay for you to get a housing stabilization worker, all of that. And so I think there are ways in which, again, right now, I don't want to imply we don't need more money. Of course we need more money, but we need better aligned money. Like the current money is kind of being like not well, it's just not aligned well. And again, intentionality. If you intentionally map your ecosystem, you intentionally designate somebody in the hub, you intentionally designate the roles of the spokes, you intentionally align funding streams, and you don't just think in the short term, but you make investments in the long term. Because as a pediatrician, we forget kids and families a lot in this conversation. We focus a lot on these like high cost, high need adults, but they once were kids, right? And things happened to them when they were kids that put them on the road to be high cost, high need adults. And so are there ways in which we can start to think about it? And I end up thinking that is a financial market, right? I don't view capitalism as a dirty word. I view unregulated capitalism as the dirty word. So it's how do you regulate that market to align those dollars, either through carrot incentives or stick, where you require it, and you basically think of ways to do it. But you're absolutely right. If I didn't emphasize enough, community voice, and I mean really centering on community voice. If you don't have that ingredient, like you can spend all the money you want. It's not going to work. We've actually started to pilot an equitable development report card that has 4 sections, and one of them is how well have you centered on community voice. And I do think I haven't quite grasped on how you, again, like don't make it a checkbox, right? Because it's real, right? It's like, it's authentic, but I do think that that is the holy grail. If you can do it, then I think I really think Greensboro can do it. And that to me becomes really important because we need more examples of how you gentrify a city without displacing people. You do. And not only gentrify without displacing people, but that the economic opportunity to grow goes to the people who are the most affected, right? So it's not just outside money coming in and making money. It's people who are here being able to start small businesses and grow and buy a house and be able to be in the community. Those 3 parts are really important. And I just think we're getting there. What I say is, 10 years ago, I used to give this talk and people were like, really, is housing and health connected? Are you sure? And we don't have to have that conversation anymore. Everyone knows it's connected. So now it's like, what do we do about it? How do we set up the models so that in 10 more years we say, did we ever not talk to each other? Did we ever not do what? And I just think that there are ways in which we can do it together, and I think you will do it, and I look forward to hearing more and coming back. All right, thank you very much.